Hello, my name is Sophia and I'm going to be talking about the pharmacological management of chronic pain in pregnancy. So what is pain? Pain is described as an unpleasant sensory and emotional experience that is associated with actual or potential tissue damage. And chronic pain is broadly defined as pain that persists past the healing phase following an injury. And the NICE guidelines define chronic pain as pain that persists or reoccurs for more than 3 months. So pain in pregnancy is common. Pregnancy causes many changes and can exacerbate prior non-obstetrical chronic pain conditions, as well as causing both acute and chronic pain conditions that are new. So changes such as the weight of the baby, relaxation of ligaments, weight gain, postural changes, pelvic floor dysfunction, these can all lead to things such as back pain, pelvic pain, ankle and leg pain, and even migraines. So the overall prevalence of pregnant women with chronic pre-existing chronic pain conditions is unknown, but smaller studies have reported that chronic pain conditions are prevalent in around 30% of pregnant women, and the 3 most common chronic conditions are chronic neck and back pain and chronic headaches. So one study found that around 95% of pregnant women with chronic pain were taking at least one analgesic, with nearly half of them taking paracetamol and or opioids. And around 20% were utilising non-pharmacological options. This highlights that it's necessary for clinicians to be aware of medication options for pregnant women. Achieving optimal pain management in chronic pain is already difficult in itself, let alone it being further complicated by pregnancy, where you need to consider the risk-benefit ratio for both the mother and the fetus, as well as the future child. But data supporting the prevalence, course and management of chronic pain conditions are very limited, which makes this even more difficult. So how do women access information about medication? So a study found that around 70% of pregnant women who wanted information on medication approached a midwife or nurse, around 50% approached a doctor, and around 45% even approached a pharmacist for advice as well. Pregnant women use a variety of sources, and nearly 50% would first search on the internet for advice before consulting someone else. But unfortunately, studies have shown that there's inconsistent and even dangerous advice for patients online for them to find. And this highlights that there needs to be, that many members of staff need to be informed, not just the midwife or the doctor, but pharmacists as well, about medication choices in pregnancy, as well as having a more comprehensive resource for both the layman and the professional so that everyone can access reliable information. So who is responsible for managing pain in pregnancy? Most chronic pain patients will be managed in primary care, but studies have shown that across the UK there is evidence of wide variation in the resources that are provided and the clinical practice. And there's a general lack of knowledge about chronic pain and the management options that are available. So NICE does provide specific guidance for management of chronic pain in conditions such as osteoarthritis, soft tissue disorders, musculoskeletal disorders, and neuropathic pain, but there is no guidance at all for pregnancy. And it is surprising that robust guidance is published on other aspects of antenatal care and pain management, but only during labour. But there's no guidelines on treating pain or chronic pain at all during pregnancy, which makes it very difficult. So what are the attitudes towards pain medication from the patient's perspective? So many women discontinue analgesics upon knowledge of conception or avoid the use of analgesics during pregnancy because they're worried about fetal safety. Over 70% of women deliberately avoid medicines during pregnancy due to fear of harming the fetus. And around 60% of women reported that they would rather suffer as long as possible before taking any medication at all. Studies, however, do show that women overestimate the risks of taking medications during pregnancy, and this highlights the need that clinicians need to counsel patients of the baseline risks for things like miscarriage or congenital abnormalities, despite the use of medication. More work needs to be done to explore these concerns with pregnant women at the outset in order to address their beliefs and concerns regarding medications and explain the risks and benefits of each option, as even paracetamol is avoided by a lot of women during pregnancy. So other concerns of pregnant women, as well as harming the fetus, pregnant women are concerned about judgment from clinicians. One study found that in women with lower back pain, only 30% of women felt comfortable discussing their pain symptoms with their clinician. And there are numerous reports on online forums of women being judged by their doctors or being given comments that aren't very helpful. So here's just a few that I found. So women are saying they got different advice from different people. Whenever they talk to their doctor, they get a blank face and shaking of the head as, you know, they're being selfish, choosing to have pain medication. You know, the information is so limited. GP says come off everything. You know, women not being referred for pain relief. And, you know, women are just, you know, not getting very good advice from their clinician. And this is something that should really be addressed. So what studies have there been out there about the healthcare professionals' attitudes towards pain medication in pregnancy? So pain is often dismissed and justified as being a normal feature of pregnancy, and quite a few studies have found that this is attitudes of quite a few clinicians. There was one study in pregnant women with lower back pain. 75% of the healthcare professionals did not make any recommendations to manage the patient's pain symptoms, which is quite appalling. There was a very interesting study which investigated the management of pregnant women with chronic lower back pain that was managed by opioids, and found that doctors actually self-reported feeling less compassion for these women who chose to stay on their opioids. And over 50% of them suspected that the woman was exaggerating their pain and they didn't really need this medication, and suspected them of having ulterior motives and referring them to addiction services. Only 29% of physicians in the study were willing to re-prescribe the same opioid that the patient was already taking, and would instead like to swap the patient or discontinue their opioid medication entirely, despite studies showing that this can be dangerous to do during pregnancy. Opioid requirements for patients on chronic opioid therapy do increase during pregnancy, yet many healthcare professionals are reluctant to re-prescribe opioids or, you know, stopping the opioids entirely. Interestingly, this study also found that the top concern for healthcare professionals for prescribing opioid medication during pregnancy for Black patients was fetal harm, whereas for white patients, they were more concerned about opioid abuse. So what are the effects of poorly managed chronic pain on the mother? So it can affect all aspects of a patient's life, from their mood to their social, mental well-being, to how they function in society. And suddenly stopping analgesics has been shown to cause adverse effects on the fetus. And if women are not having their pain managed properly, it can lead to them using inappropriate choices of over-the-counter medications or herbal remedies, or even overusing over-the-counter medications to cope. So what pain medications are safe to use in pregnancy then? Well, that's not very easy to answer, because there's numerous issues with doing studies on pregnant women taking medications. But here is what I found from a few studies. I've tried to kind of come up with charts of what is safe and at which point of pregnancy it is safe to take. But further research really is needed, because there's very little safety data and there's lots of inconsistent results across studies. And as you can see here, most medications haven't been studied at all, because it's not very ethical to conduct these studies. So going forward, what can be done? So if GPs and obstetricians are, being shown in studies to be reluctant to prescribe medications such as opioids, then why are so few women being referred to pain management clinics? Unfortunately, pregnancy is often an exclusion criteria for chronic pain programs, and limited funding and coverage means that waiting lists for pain clinics can be many months long, at which point the woman may not be pregnant anymore. So what should be done going forward? So one Australian study had come up with this algorithm that can assist clinicians. So easy to follow and quick reference guides like these should be made readily available for healthcare professionals, especially GPs who are very short of time. And guidelines should be made for NICE that cover things such as suitable pain medication per trimester, who should manage the pregnant women's pain, and who they should refer to for further advice or escalation of pain management, so that there are, clear guidelines of where people can access more information. And there needs to be better training for healthcare professionals to cover things such as medication safety in pregnancy, opioid management and withdrawal in pregnancy, clarification of who manages the pain, as well as awareness of biases affecting clinical decision making. So the final note that is something to consider is that up to 1 in 2 pregnancies are unplanned, and women may go through pregnancy on pain medication that is contraindicated. Interestingly, studies have shown that less than a quarter of these women on long-term opioid pick up their prescription for their contraception. So this could be a great opportunity for a public health intervention. And that's the end of my presentation.